I hope that you have settled down, have some engaging conversations, and are ready for our next plenary session. Now let's welcome Professor Aaron Ciechanover to talk about the revolution of personalized medicine. Are we going to cure all diseases, and at what price? The Q&A session will be moderated by Dr. Su Sing Yi from the Agency for Science, Technology and Research. Prof Ciechanover, please.
Well, good morning, everybody. You can hear me? Okay. So what I'm going to tell you today is probably on the greatest revolution that medicine has undergone or is still undergoing these days, which will expand the scope of medicine in a very big way. But in order to understand the roots of this revolution, I would give you a little bit of an historical background. So, of course, the dream of people is to remain young forever, and more than that, to remain healthy forever. So we want to live endlessly and jog every morning and bike and so on and so forth. And the question is whether there will be a cure to all diseases. Well, it's hard to say because, once you are curing one disease, another disease is coming. And we learn it from history. Because think about 120 years ago, 124 years ago, at the turn of the century, people were living on the average 45, 50 years. And the Greeks, the old Greeks and the Egyptians and the Babylonians were living on the average about 30 years. So it took about 4,000 years to the turn of the 20th century to extend life from about 30 to 50, and then one single century, the 20th century, to add additional 30 to 35 years to our life. We are living nowadays in developed countries 80 to 85 years. So what happened in this 20th century, then we added so much to our lifespan that didn't occur along the preceding 4,000 years. A lot of things happened, and they are all in science and technology, of course. It's vaccination, it's antibiotics, it's imaging, it's diet, it's operation, anesthesiology, and so on and so forth, healthy lifestyle. All those were piling together in order to add another 35 years. It's a huge amount of time that we added, and the question is whether the tendency is going to continue. Well, the prediction is that we are going to plateau at around 110, 115, but it's not clear yet, because now we are able even to repair genes, to repair a mutation, CRISPR-Cas, and so on and so forth. So we are not clear about it. Of course, there is a major collision now between what we know in science and technology and between the economy, because people are using about 80 to 90% of their health expenses in the last very 10 years of their lives. And when they don't work, they are living on pension, they are dependent on their offsprings, and so on and so forth, and it's going to increase. So what about this prediction? So at the turn of the previous century, we died of infections, of cholera, of tetanus, and so on. Now we defeated these diseases. So new diseases, which are age-related, started to float. We started to get heart diseases. People didn't die of heart diseases when they were 45, dying of infection. People didn't die of cancer, which is a bona fide age-related disease. Of course, there is cancer in children, but the numbers are very, very low, about 2% or 3% and so on. Neurodegeneration, people don't die of Alzheimer's disease at the age of 40. So all these new diseases, the vascular diseases, the neurodegenerative diseases, the malignancies, are all they are handmade diseases in the sense, of course, we are not blaming humankind for generating them. They're all man-made diseases that are the result of improving our lifestyle, of living longer, and we don't know what is waiting for us still behind the corner, though we believe that we more or less understand the full scope of the diseases. So we are going to defeat most of the diseases. We are, I think, well advanced in cancer. Neurodegeneration is still behind, but as I said, we still don't know about new diseases that might wait for us behind the corner. So let's think of where medicine is going these days. I give you kind of an overview. So, of course, drug industry, and that's what I'm going to focus mostly. The drugs have always been with us since the old Egyptian times, but there are also other avenues that medicine is moving. For example, artificial and not so artificial organs. So initially we started with artificial organs. We can change joints by joints made of titanium, of other metals, and so on and so forth. But gradually we are moving, we are starting to move to animal-derived organs. So we are using pigs, or we are trying to use pigs, humanized pigs, from which we removed a whole lot of genes, either genes that are causing viral diseases that are somehow embedded in the DNA of the pig. Somehow the pig is regarded as the closest. Well, let's don't go to further, deeper comparison. The closest animal as far as size is concerned to fit human organs. Heart, for example, we are also removing from the pig the immune system to make it humanized. We try to implant a human disease. So the transfer of organs, because of shortage of man-to-man organs and donation, so we are trying to use animals. So gradually we are going to replace the artificial organs made of materials, of chemical materials, with organs that are coming from animals. We are still not there. So this is another direction that medicine is going. And of course, another direction is, of course, what we call engineering or genetic engineering, and it's going to various stages. For example, I mentioned CRISPR-Cas, the ability to edit genes and to correct mutations and so on and so forth. And we are already using it, for example, in a disease called sickle cell anemia, which is a mutation in the hemoglobin that causes the red blood cells to sickle and to cause many problems. So you see that besides drugs, medicine is going in different directions. But let's go to personalized medicine and see the roots of it. So the first revolution was an era of incidental discovery. Take, for example, aspirin, one of the most used drugs, probably the most used drug that the pharmacopoeia has ever seen, in tons, I mean, in tons. Aspirin is, was used initially in order to alleviate pain. Actually, it was developed by a German company, by Bayer, from a derivative of a plant, but then it was very bitter, and the bitterness was removed. But then it discovered that aspirin has many other characteristics beside pain relieving and fever relieving, and that's anti-inflammatory characteristics. And as you know, inflammation is the one of the most important preceding factors in malignancy. Chronic inflammation leads to malignancy, so people are using aspirin in order to prevent chronic inflammation that may lead to cancer. Aspirin also was discovered to have an anticoagulant effect against coagulation, so it's being used, not exactly aspirin, but its derivatives, in order to prevent coagulation in the coronary artery for people that have suffered from myocardial infarction. And aspirin really became a very, very broad drug, though it was discovered more than a century ago by Bayer as a treatment for rheumatoid arthritis, which is a disease that, a painful disease that somehow paralyzes the joints, and people cannot even do simple movements like buttoning their shirt or cutting their food or drying themselves after the shower, and so on and so forth. But aspirin was discovered completely by coincidence. Another very famous drug that was discovered by coincidence is, of course, the first antibiotic, penicillin, and it was discovered by Sir Alexander Fleming, a British microbiologist, and he somehow by mistake left a petri dish open on the original petri dish is, by the way, in the British Museum, open on the table, and there was a smear of bacteria that was growing on this dish, but because the dish was left open on the bench along the weekend, when he came back after the weekend, he saw a colony of fungi, of a fungus growing on the dish. There are spores of fungi that are contaminating the air that we breathe, and one fell on this nutritious media. But what Fleming noted, that there is a halo here. The bacteria couldn't reach all the way to the very border of the fungal colony, And he surmised that the fungus is secreting a material that he called antibiotic, or anti-against bios life. And it turned out to be true. He was not a chemist, but two other chemists, Aaron Ciechanover and Howard, purified the material, and penicillin, the first antibiotic, came to the world. And indeed, it was even used by the Allies during the invasion to Normandy in World War II, and saved the lives of hundreds of thousands of wounded soldiers. But people also learned the lesson that fungi secrete antibiotics in order to protect themselves from bacterial attack. And the second antibiotic was discovered by Waxman at New Jersey, the streptomycin that came from Streptomyces. And then many more antibiotics were discovered. Now we are making them synthetically, but the discovery was completely coincidental. So two drugs that are very useful to these very days were discovered by a coincidence. But coincidence is not a way to discover drugs. And then came the era again. It was because of the development mostly of two of the bride and the bridegroom. I don't know who is the bride and who is the bridegroom, but one of them is chemistry, of course. People learned how to synthesize chemicals, and on the way to a synthesis of any defined chemical, there are many intermediate steps, and libraries of millions of compounds were generated along the years. So this is one side of the marriage. The other side of the marriage is, of course, animal models, but not only animal models, but tissue culture cells that can mimic somehow models. We can grow cancer cells in the dish. They are not cancer yet, but nevertheless, they are cancer cells. And I think that the marriage between the two brought the second revolution, which is high-throughput brute force. You have cells growing in a dish on multiple wells. On the other hand, you have libraries, and even without knowing the mechanism, without even guessing the mechanism, you are putting a little of each material on the cells. It's all automated. If you go to the big screening facilities of the big pharma companies, you'll see how it's working. And once, for example, if you are growing a cancer cell, there is an inhibition of growth, or if there is cholesterol secreting cell, there is inhibition of secretion of cholesterol. You have a lead. You don't have a drug. You have the beginning of a drug. You have a lead, and you can continue with the lead, toxicity, and so on and so forth, until at the very end, after phase 1 and phase 2 and phase 3 clinical trials, you get a drug. And one of the drugs that came, a very famous drug, are statins. Statins are anti-cholesterol drugs. They inhibit the first step in the biosynthesis of cholesterol, the step that is catalyzed by HMG-CoA reductase. It's the first rate-limiting step in cholesterol biosynthesis. And they are being used for people that are suffering for hypercholesterolemia, and they save the lives and morbidity and mortality of millions of people that either had first heart attack or a heart attack was prevented for them by taking the drug as a preventive drug. And it was discovered by Akira Endo, a Japanese pharmacist that worked in a pharma company in Japan, who screened the library of natural products that are coming from plant in Japan, and he discovered the first statin. And Park Davis bought the patent. They developed the first statin, and now it's a huge multi-billion-dollar industry. But we cannot rely on screening, and the reason that we cannot rely on screening, though theoretically you can say, okay, let's screen for each disease, because the diseases, the models that we have, do not mimic the real diseases. For example, take psychiatric diseases. I mean, there is no model for psychiatric diseases, not even in animals. But even the real diseases, the models are not correct. The mouse is a good model, but not more than a good model. You know, the mouse are all genetically inbred. They are sitting in cages. They have the same diet. We turn the light on at 8 o'clock in the morning. We turn it off at 8 o'clock in the evening. It's not the real model. And actually, what happens with human beings, which we realized only very late, that there are not two human beings that walk on the face of this planet. They're identical, not even identical twins, because of epigenetic changes. So even epigenetic twins that are identical in utero, once they are seeing the light of the sun and the road started to divert from one another, different diet, different exposure, different climate, different everything, they start to be different. So the variety really is enormous, and therefore, there is no one drug that can cure the same disease in all patients, because there is nothing like the same disease. There is not such a thing that is the same disease in the same patient. Same disease, I mean, the disease can be the same. It can be the same very mutation in the RAS oncogene, but the host is different. So the environment is different. So the disease can be different because the same disease can stem from a different mutation. Take breast cancer that we are going to talk in a minute, or it can reside in a different environment, in a different host. And therefore, we see a huge variety. So of course, the revolution started with this very famous couple with Jim Watson and Francis Crick. The discovery of the DNA and the development ever since was amazing. Probably the most exciting development in biology, in life sciences, and in medicine ever since the early 50s when this discovery was made. And the future drugs are going to be based on our DNA, on our environment. So we are moving now from what we call pajama type of medicine. Why it's pajama? Because when you buy pajama and you'll go to the store, you'll find 3 sizes, small, medium, and large, and the rest will be fitted by the rubber band. We are moving into suit type of medicine. We are going to tailor it to the needs of the patient. Now, people are asking me, will there be drugs for 8 billion people that inhabit the planet? No, we don't need so many, because at the end of the day, we are going to stratify the diseases according to the cause of the disease, to the mutation, and mostly also according to the environment as much as we can. But nevertheless, there will be many more drugs than we have today for what we call, quote unquote, by mistake, a single disease. And the reason for this revolution came from, it's not only from the discovery of the DNA and from the discovery of the variety, but also from the observation. Because if you have a group of patients that are starting the same very day with the same so-called disease, let's say prostate cancer, breast cancer, doesn't matter which, and you give them the gold standard treatment that is available for this very day, they will end up in 2 different ways. One group will survive, will heal, depends, of course, on the disease. And another group either will deteriorate and die, the same very disease, so-called, or will carry the disease chronically and deteriorate slowly, or will carry it for the rest of their lives. Depends, of course, on the disease. And people wondered, what's the reason? Why is it? We have a tumor in the breast. We take the tumor out, we irradiate it, we give chemotherapy. Doesn't matter what we do, depends on the disease. And nevertheless, people behave differently. So then came the realization that the DNA is different, the mutation in the tumor will be different. But not only that, nowadays we realize that even within a single tumor, we are doing, therefore, single-cell analysis. Cells in the same tumor are differing from one another, and they are changing along the treatment. So the complexity is much bigger than we thought it is, and we still don't have an answer, even with personalized medicine, to this complexity. I'll give you just a brief example on breast cancer. You have 2 samples here of breast cancer on the lower left side of the slide, and you can see breast cancer A and breast cancer B. You can always tell the difference between the 2. One is a bigger island, the other is scattered island, but that's only to the eyes of the pathologist. But then the pathologist stained it. He stained it with an antibody to the estrogen receptor. And you can see that the left slide didn't stain at all, but the right slide was stained. So the right woman, the biopsy that was taken from the right woman, she has a mutation in the estrogen receptor. And she can be treated with a drug that counteracts the excess activity of the estrogen receptor, which is tamoxifen. But if we give tamoxifen to the first woman, nothing will happen. Well, something will happen. She will continue to deteriorate. And it will be a waste of hope and a waste of money. And so you see that we are already trying to stratify the disease according to their molecular base. And the same is true for another woman. So this woman might have a problem with the EGF receptor. So tamoxifen will not be good for her. Instead, we have to give her Herceptin, which is another antibody that clusters the mutated EGF receptor and sends it to degradation in the lysosome. And then there is a woman that has a mutation in the progesterone receptor. And then there is a group of women that have none of the 3, and we call them triple negative, and they are the worst. Now, but we are going to find out what's happening with them, because they do have cancer, and we do need to treat them. So we call them triple negative, kind of do not belong to any of the three that we know. But of course, we are going to understand the disease. We are going to know what to do with them in the future. So that's the essence of personalized medicine. And beside, there is another issue, which we see in the hospitals for the physicians among you. I forgot my days in the hospital, but nevertheless, the extreme cases I do remember. There are many adverse drug effects, adverse drug reaction. People are sensitive. You know, typically in the hospital, when you'll come, they'll ask you whether you are sensitive to penicillin or to drugs, but there is not a single drug that people are not sensitive to it. And the sensitivity, you know, if it's only a rash, an itchy rash, it's okay, but people die out of it. You can die of anaphylactic shock, you can die of a cytokine storm, you can die. People are dying in the hospital or develop very severe syndrome due to sensitivity that we cannot predict. We just cannot predict. And this is also the same very issue like a response to drug. It might be a SNP, it might be a gene, it might be, and gradually we are starting to already sort out what's going on with these people. So take the, drug reaction. Drug can be efficient. It can be efficient and have side effects. And the side effect can be so severe that we have to take the patient out of the drug, off the drug. It can have only side effect with no benefit, and it can have nothing. So you see, when you give a drug, you don't know. It's all about statistics. We know the statistics, but now we aim to understand it at the molecular level. So if you think of old medicine, I would say old oncology, for example, and old I mean 10 years, 15 years. It's not old like I am old. It's much younger than I am. When people came with a tumor, we knew 3 lines. We knew surgery, if we could operate on it and debulk the tumor. We knew chemotherapy, and we knew radiotherapy, which are huge cannons that have huge side effects. And nowadays, we are trying to narrow the diagnosis to a mutation and to build drugs that will fit into the mutation. So it will take a lot of initially structural biology, but now it's much easier. We don't need Ada Yonat, my friend, to spend 15 or 20 years in order to unravel the structure of the ribosome. Because of the so many structures that were already unraveled by Ada and her colleague and Kendrew and Perutz and the people that preceded them, AlphaFold came into the picture, and now we can understand the structure very well. We can then module the mutation, and then the chemist will come and fit the drug. We don't have to screen big libraries anymore. Oh, we still do. But these days are going to pass because we are going to have a very strong computational tools, both on the target and on the modulator, that will make the fitting much faster, much more accurate, and much cheaper. So that's where we are heading with these new tools. And of course, I just mentioned to you the fact that there are not 2 people that walk on the face of Earth that are similar. I'm not talking male and female, tall and low, fat and thin, living in different places. And therefore, each of us will need fitting of the drug to the very disease. So let me now move very quickly in the time left. And you see that it's all based on the initial discovery. We now can sequence it's also based on technology. We can now sequence the genome much faster. You remember the first genome took 7 years and about $700 or $800 million. Now we can do it for less than a few $1,000s, and it's going down, full genome, I mean, and in few hours. And also the software for processing are much quicker. We are now, in every hospital, we are now sequencing all the oncogenes. There are about 250 oncogenes that we can learn about the mutation. So it's moving very, very fast. And the issues here are, of course, the price. Initially, the price is going to be very high. And unfortunately, this type of medicine will not be accessible to everybody. But gradually, I hope that the price will go down and the accessibility will increase. But there are also ethical issues here. And I'm going to point out in the last few minutes that I have to the ethical issue. One is, of course, the genetic privacy. Because what will happen now when a patient will come to any diagnosis, the first thing to do will be sequencing. Either SNP sequencing, or partial sequencing, or complete sequencing, or exon sequencing. I will not go into details, but it will be sequencing. And in the sequencing, there will be a lot of information that will be unraveled that may be beyond the disease that we may want to know or we may not want to know. But it's not only us who may want or may not want to know. It's other agencies that may want or may not want to know. It might be the government. It might be the insurance companies. Because until now, the insurance company, you have to fill some kind of questionnaire, whether your mother had heart attack and whether your father had cancer or so on and so forth. It's all very superficial and almost completely unpredictable. But unpredictable as far as in the eyes of the insurance company. But if they have the full sequence, they have a much better information, and this information can be leaked. And it can be leaked to people that, may blackmail you, ransom you, or the insurance company will not want to insure you. Or you yourself might tell the insurance company, hey guy, I'm 50 years old, I'm a careful driver, I'm not a criminal, and here is my neighbor, the same very age, and our insurance is the same. But he is a criminal, there is cancer in his family, he's involved in road accident every day, he's drunken. Why should I share my policy with him? Why should, instead of charging me $5,000 and him $5,000 for the annual policy, charge him $9,999 and charge me $1? Because insurance companies are all about risk. All what they want to see is that more money comes in than the money that they spend on the policies. So there might be even a demand from patients. And there might be even demand from people like us who, fall in love and want to know whom we marry. Even now, think about it. We are married in circles. We don't admit it, but we do. We are married in religious circle, in skin color circle, in educational circle, in socioeconomic circle, you name it. We are not floating free in the clouds. So why not to have a little bit of genetic information of how our offsprings are going to look like? But the genetic information, as I said, is going to leak. And of course, Angelina Jolie, I think, symbolizes more than anything this revolution by coming out and say, my mother died of breast cancer, my aunt died of ovarian cancer. There is something common to these two diseases, which is BRCA1. Why shouldn't I test myself? The aunt was the sister of the mother, and she was tested positive for a mutation in BRCA1 that carries 80% chance for breast cancer, 40% chance for ovarian cancer. She was found positive, and she announced to the public that she's going to undergo 2 operations, 1 removing her breast and 2 removing her ovaries. She did a great service, but of course, she didn't solve the problem of her offspring, of the daughters and even the sons. So this is another issue that, knowledge is good, but carries also some burdensome information in it. But let me go very quickly just to the very last one. When I was a medical student, we were educated that there are 3 pillars to medicine. One is the disease, the other one is the patient, and the other one is the treatment. And all 3 of them are shaking heavily these days. They are not going to be anymore. The patient used to be the old patient with a nice doctor that takes your pulse. The patient today might be the sperm or the egg or the embryo or the in vitro generated embryo in the test tube. So we don't have to wait for the patient for 50 years to develop something. If we can discover it, not all diseases can be discovered at a very early stage because some of them are acquired, mutations are acquired, but the inherited one, for sure. So why not to treat the sperm or the egg? And the same for the disease. The disease, as I said, in this case, it's a nice woman that cannot get up to work, but the disease, a mutation in P53 or a mutation in RAS, can be discovered in the sperm. So should we define the sperm as a sick sperm? Yes, maybe yes. It all depends on semantic. Definitions are up to us to decide. And you can see what are the implications. So newly developed blood tests can detect cancer 4 years before conventional method blood tests can identify early stages. The same for Alzheimer, and so on and so forth. So are we ready to take now a test for circulating DNA that came out of a tiny little tumor that we can amplify, and it's already circulating in our blood? What will be the implication for the insurance? What will be the family implications? I feel healthy. I got up in the morning ready to lecture to you. I don't know what's going on in my circulation, but proteomic and genomics and transcriptomic might tell me. So again, it has huge implications, not only about on me, but about the health services, the insurance company, and so on and so forth. And we are moving there. We are clearly moving there. So that's about the disease and the patient. We talked about the patient. The patient can be a sperm. The patient can be an egg. The patient can be a fertilized egg at different stages. We are now using in vitro fertilization, and then we implant the embryo in the uterus. So these are going to change with all, and the treatment. The treatment, as I said, might not be drug. The treatment might be this little forceps that takes a little piece of DNA, the mutated mutation in sickle cell anemia in the beta chain, and I think it's the 4th position of the beta chain of hemoglobin, and replace it with the right amino acid, and bang, we are done. And it's not imagination, it's being done already these days. So I think that medical studies are going to change in a very dramatic way as the 3 pillars are already shaking. We are getting ready to it in our medical school. We are not, it will take some time, but we are getting ready for it. And the prize that I mentioned at the very title of my talk that you probably forgot, the price is going to be not only in dollars, at least initially, but mostly on ourselves. I mean, this new medicine is going to mean a lot to our being part of the revolution and taking very heavy decisions that until now was taken by others, by the doctors who was our advisors. We shall have to take decisions for ourselves. What do we want to know? What we don't want to know? What is the responsibility that we have about our employment, about our family, about our children, and so on and so forth. So the price is going to be quiet. I wouldn't say heavy. Maybe it's a negative context. It's going to be very different than what it used to be. So thank you very much.
You'll be taking the first chair over here. Thank you so much, Prof Aaron, for the wonderful talk and on the 3 different revolutions, right? The first one is by chance, and the second is brute force screening, and the third is personalized medicine. So while I wait for the audience to come to the mic to perhaps pose a question, my first question to you is, do you see a role of AI in the data security and the amount of data that's coming through with all this high-throughput medicine?
Yeah, the question was on AI. Of course, AI, but AI is a tool. Initially, I remember when I used doing my first mutation when I was a postdoc at MIT, I did it in rooms that were kind of overpressurized via 3 levels because people were afraid that the bacteria will fly out and will cause infection of the whole world. It's a technology. It's just a technology. Maybe other people in the computer, very helpful technology. It can look, I think that one advantage of AI is that it looks blindly. When the pathologist looked at a sample, he looks for something that he knows already. He's biased a priori. The AI looks at all the features. Maybe cancer can be discovered by a corrugated corner of the cell that nobody ever paid attention to. But the AI will look into it. If it will scan enough, a big enough number of cancers, and it will see the difference between benign and malignant cells. So it has a huge advantage by being blind to something that we are biased to. It can look into big data and draw conclusions. For myself, maybe because I'm so old, I don't want my grants to be written by AI. I don't want my letters to be written by AI. I want to do it myself. I'm proud of what I do. So it's a matter of taste. I believe that it's going to change. AI will improve. For now, it's still far from perfect as far as thinking is concerned and generating complex idea, but it will get there, no doubt. It will get there. It has a role. It has a very important role.
Towards the end, you mentioned about escalating costs for personalized medicine. Do you think AI would have a role in kind of controlling that cost by perhaps implementing targeted clinical trials to predict efficiency and therefore reduce the number of patients that would be required for clinical trials, for example.
About AI?
Yeah, AI, being able to bring
think
that
that
cost of R&D down.
The big thing, of course, is to stratify, to look at big data and to find new mutations and to analyze it, to see the cause, of course, because some findings can be hitchhikers or bystanders. They are not necessarily causative, so we have to pull out the causative out of the bystanders. Yes, it's very important, and it's here to stay and to grow bigger and to play an important role. I think that one thing that people are talking about, and I think that the EU started already doing it, and in the United States, is regulation. Of course, like any other technology, we need to regulate it from people that abuse it, and it can be abused. We already know how just the social networks are being abused, what negative role they played during the COVID-19. Just the information, the misinformation. This is not AI. Just the utilization of the social networks, a very negative effect. Remember President Trump, hydroxychloroquine, all the drugs that he tried to promote, and so on and so forth. So AI is fold dangerous, and it will need regulation like any other technology.
Great, thank you. Now we have a queue. Maybe we'll start from there. Question, please.
Thanks very much for your talk. I'm from the University of Melbourne. My name's Yushi. I wanted to hear your insights on two particular problems that come with the idea of genomics screening and targeted drug therapy. With the behavioral kind of implications of screening, meaning that for patients who have had screening of their genome and find particular mutations that maybe lead them to more prone to getting diseases, how do you then mitigate the psychological impact of these kind of things on patients who are otherwise well? It's really difficult to make a well patient better, but you can certainly make them worse by giving them that information. And on the contrary, there may be even the problem of having a genomic sequence which is all clear, and people then start feeling invincible and then going down the pathway of altering their behavior towards a more unhealthy kind of lifestyle. What are your thoughts, and how do you kind of address those behavioral implications on what you've talked about today? Thank you.
The question was about mass screening?
No, the question was more kind of how do we deal with that information? Because when someone is being told you have a mutation, but there's no treatment, or you feel completely mutation-free, then they go on a lifestyle of debauchery.
Yeah, it has also to do with mass screening, because we are doing some mass screening of babies, of newly born babies, for common diseases, and it's expanding as we talk all the time. I think that the screening is useful when there is something to do about the disease, when there is a drug or some treatment. If it's just an information, I wouldn't do it. But the screening can give you the full information. Then there is a legal issue to whom this information belongs. You provided the material, not you. The patient provided the material, so the DNA belongs to the patient. So the question is whether the information that comes out of the computer should be fully given to the patient if there is nothing to do about it currently. It's still debatable by legal experts and so on and so forth. It's still, my opinion is that you should disclose whatever is beneficial. But otherwise, why to do it? But it should be kept, because what is not beneficial today might be beneficial tomorrow. So we need to develop plans that will alert us, there is a new drug there that is already there, and we can do something about it. So maybe this might be the solution.
Great. Thank you. We invite a question from there.
Hi. Thank you for the talk. My name is Yong Ray, and I'm a PhD student at UC San Diego. I have a question about your thoughts about eugenics, because rather than change the DNA of a person, like any defects of the DNA after it's set, why not just change it from the start? Like right from the start, you engineer it, and then you don't have all these problems that comes.
Eugenics. So basically,
what?
Eugenics. Basically, he's asking the question if you could just determine someone's genetics right from the beginning, rather than treating it after it's being found out.
Yeah, because in both cases, you will change the DNA anyway. So might as well change it from the start, or am I missing something? Yeah, not a biologist.
ethically loaded question, essentially.
What?
So he's asking about, what are your thoughts about genetically modifying people or determining their genetic makeup right from the beginning rather than correcting it at a later stage? It's a huge question.
I think that we should leave some space for still, emotions, love, laugh, rather than trying to control everything.
Yeah, I guess. Thank you.
No, but to be serious, I think that we are, people are afraid. We are talking about, that young people don't go to science because they're afraid, and that people are afraid of scientists, that one day we shall clone a whole army that will somehow pop out of the ground and will destroy humanity. I think that regulation is of utmost importance here. I don't want to go into detail because there are still many questions, and I'm here for the next 2 days, so we can talk also outside. Remember the case of this Chinese scientist that did this experiment, which was much too early, was a failure. And he had his own mind why he wants it. I don't want to go into discussion what happened with this Genki Hay. We should be very careful about gene editing. I think that the American Society of Human Genetics and people have outlined what is, allowed and what is not allowed, what should be prevented and what shouldn't be prevented. It should be tightly regulated, really tightly regulated. We don't want to clone people. We don't want to change people. I think that the diversity of the world and the big aquarium we are living in is nice enough not to spoil it.
So we have time for two more quick questions, maybe one from the lady there. Yeah.
I'm Isuli from Nanyang Technological University, Singapore. I would like to know your thoughts about the potential of AI in replacing animal model in biomedical research, especially in drug testing.
AI in what? In converting animal models into?
For drug
in
testing.
replacing.
To replace animal models or in vitro models in
To replace animal models.
Yeah.
Yeah, this is a very tough question, I must admit. There is some progress, but it's not satisfactory. It's called organoids. Organoids, people that don't know, are kind of something that mimics the original tissue. You can take, for example, a cancer from patient, and you can put it in culture, make a little, and then try, for example, chemotherapy, instead of trying it on animal models. But organoid, it still doesn't provide the environment, the changes that are occurring within the tumor. I think that people should be very careful when they are approaching an animal. It can be limited to a large extent. I don't think we can stop it altogether. And I don't think even that people will agree, even those that support it, to take a drug from the pharmacy that will be said on it, in a red label, this drug has not been tried on animals, but only on cells. I doubt that people will agree to it. Animal gives you a proof of concept, but at the end of the day, I can tell you that there is an animal worse than the mouse because we are making clinical trials. We are not putting any drug to the market without trying it on a rabbit called human being. There is phase 1, which is a very limited size. It's toxicity and side effects, very limited size. Then there is phase 2, and then there is a multi-center, double-blind, that is made on thousands of people. And I can tell you that out of these 1,000, half of them get either a placebo or the previous drug that might be worse or even better than the drug that is being tried. We cannot put a drug in the market without trying it. Let it be an animal or let it be the human being, though we are trying to be very, very careful. And I think that the movement against animal trials, that really evolved along the years, is a very positive one, but it shouldn't cross the limits that will hurt development of future drugs.
Thank you.
Thank you very much. I'm afraid we have run out of time for questions, so perhaps we can have a chat outside with Prof Aaron after the talk. Thank you. Thank you again, Prof, for the wonderful talk. And